Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the ERJ. Today, I'm joined by Dr. Walter McNicholas to discuss his latest paper entitled Implementation of European National Driving Regulations for Obstructive Sleep Apnea, Challenges and Recommendations. Dr. McNicholas is the Newman Clinical Research Professor at University College Dublin and a consultant in respiratory and sleep medicine at St. Vincent's Hospital Group in Dublin, Ireland. He's also the past president of the European Sleep Research Society and a past president of the European Respiratory Society. Walter, many thanks for joining us today.
Thank you, Don. It's a pleasure to be here.
Could you tell us a little bit about your paper and perhaps specifically about the connection between obstructive sleep apnea and motor vehicle accidents?
Well, obstructive sleep apnea is widely recognized as a major risk factor for motor vehicle accidents. And the statistics over the last 30 or so years have shown that patients with untreated obstructive sleep apnea are about 3 times more likely to have a driving accident than the general population. And this would even include matched general populations. That's the bad side. The good side is that the evidence indicates pretty clearly that when these patients are treated effectively, usually with nasal CPAP, that increased risk is removed. And in actual fact, treated patients have roughly the same accident risk as an equivalent general population.
Could you tell us about the European Union directive in 2015 regarding sleep apnea and driving regulations?
This directive arose from an extended period of lobbying with the European Commission, which is the body that is responsible for developing these types of legal directives. And indeed, the lobbying goes back to an ERS task force that was funded in the late 1990s on this topic of driving safety and sleep apnea. So we've had many interactions with European Union parliamentarians and European Commission officials, and that resulted ultimately in a working group established by the European Commission to evaluate this whole relationship. And I was privileged to chair that working group, which ultimately led to a report that was accepted by the Commission, and then finally to a legally binding directive, which is mandatory now throughout all European Union member states, thus representing a population of about 450 million people. Briefly, the directive says that patients with moderate or severe obstructive sleep apnea, defined as an AHI greater than 15, associated with sleepiness, should not drive until the disorder is effectively treated. And that typically is with CPAP therapy.
Are there different recommendations for commercial drivers, such as truck drivers or Uber drivers or taxi drivers?
The directive doesn't distinguish between private and commercial drivers in the context of the criteria to indicate fitness to drive. Where the directive singles out commercial drivers is that they require more careful follow-up. And so-called Group 2 license holders, which would typically be truck and bus drivers, require an annual certification to indicate continuing fitness to drive, whereas for private drivers, it's more open-ended.
According to the directive, are the physicians who diagnose the sleep apnea patients mandated to report on the state of the sleep apnea and potential therapy or non-compliance with therapy of patients?
Well, that's an interesting question. And in fact, it was a specific question in our national survey. We surveyed ultimately over 30 countries, and it varied from country to country. In about 25 to 30% of countries, it was the physician's responsibility to certify fitness to drive. In other instances, it was a shared responsibility. And finally, in about 25 to 30% of countries, it was the patient's responsibility, and there was no specific responsibility on the physician. So obviously, in the context of where it is the physician's responsibility to certify fitness to drive, that is a particularly onerous task. And, puts a very special requirement for patient evaluation and certification.
Yeah, you mentioned therapy. If patients are on CPAP therapy, they are considered treated. Now, is there specific parameters of CPAP compliance that is used, and is daytime sleepiness reassessed after starting CPAP? Is that part of the treatment algorithm?
Well, it's specified in the directive that it is a requirement that the patient be certified as adequately treated, both in terms of sleep apnea control, but also in terms of control of sleepiness, because both factors are part of the directive. The directive requires both elevated AHI and associated sleepiness, and both of these should be controlled before the patient can be certified as fit to drive.
Can patients be treated with something other than CPAPs? For example, mandibular advancement or tonsillar surgery. Would that count as adequate therapy?
Again, the directive doesn't specify the modality of therapy, it just indicates effective treatment. So with mandibular advancement devices, one can assess the outcome in terms of symptom control, particularly sleepiness. But up until recently, it was not possible to objectively evaluate control of sleep apnea. But it must be said that the latest generation mandibular advancement devices do actually have the technical ability to monitor apnea control. So that is now feasible.
In the EU directive, with the patient's past history of motor vehicle accidents being taken into account when issuing warnings or reporting to the regulatory agencies?
The directive itself doesn't make any reference to past medical history, but there would be an encouragement, or if not an onus, on the certifying physician to take into account these relevant factors in determining fitness to drive. So clearly, if a patient has a past history of motor vehicle accident, especially if it's related to sleepiness, then that would be an important factor to take into consideration when evaluating fitness to drive.
And you mentioned part of the diagnosis, you measure apnea-hypopnea indices. In many jurisdictions, polysomnography is very restricted or limited, and so home monitoring devices are often used. Would they count towards the diagnostic criteria for obstructive sleep apnea and treatment thereof?
Absolutely. And in fact, in Europe, the norm now would be that the majority of patients being investigated for sleep apnea would have their diagnostic sleep studies performed at home, usually in the setting of a limited sleep study focused particularly on the question of sleep apnea. So it would be a relative minority of patients who would actually be studied by polysomnography in a sleep laboratory. So yes, definitely home sleep studies would be the norm in this context.
It's been almost 10 years since the directives have come down the pipeline. Have you seen any impact, or have any jurisdictions reported on the impact of these directives on sleep apnea in general, or on driving accidents, or any other outcomes that may be of relevance in this field?
There are no reported studies specifically looking at the impact of the directive on accident rates. Our study, which will shortly be published in the ERJ, is geared towards the implementation of the directive itself. And in the discussion, we clearly indicate that that's only one part of the story. The second part of the story is to demonstrate whether the implementation of the directive is effective in reducing accidents. It's something we're looking at, but the whole issue of driving accident rates is such a complex area that it isn't the easiest aspect to look at. However, it should be said that there are many studies reported in the literature going back at least 20 years, which have very clearly indicated that patients who have significant sleep apnea syndrome who are treated with CPAP are associated with a significant reduction in accident rates. One of the best known studies in this regard in the private driving population would be from Ontario in Canada, which looked at the 3 years before and after initiating CPAP in a population of OSA patients. And they compared the accident rates in the 3 years before CPAP with the accident rates in the 3 years after CPAP. And they showed that there was a threefold elevation in accident rates before initiation of CPAP compared to the general driving population. And in the 3 years after initiation of CPAP, the accident rate reverted to the general population rate, which is a pretty potent indicator. And there are many other studies, including studies in commercial drivers, showing very clearly similar types of outcomes.
Are there any last words you'd like to speak to the audience about regarding this field or in obstructive sleep apnea in general?
Well, relating to the driving risk, it's a huge problem. The global population of patients with moderate to severe sleep apnea, which is the group under consideration here, would amount to about 400 million adults with sleep apnea. And at least half of those will have significant sleepiness. So you're talking of a population at risk in the region of 200 million globally. Now, the EU is the first major geographic area to introduce official driving regulations in this regard. And huge swathes of the world are deficient in the context of regulating these patients. I mean, it's ironic that authorities regulate driving distances that commercial drivers can drive because of driver fatigue. But indeed, also patients with untreated sleep apnea are at major risk associated with driver fatigue. And one of our goals going forward is to try and promote the whole area of recognizing these patients and ensuring that they are effectively treated. What we seek to achieve is the carrot approach as opposed to the stick approach. But of course, that is an objective going forward. And in this context, I'm part of a working group that's affiliated with the World Health Organization, seeking to progress the whole area of driver sleepiness in the general context, but in this context specifically relating to areas such as sleep apnea, which is the most common medical disorder associated with excessive sleepiness.
Well, thank you. This is such an important area for not only patients, but for public health and public policy. So thank you for taking this on and shedding light on this very important topic.
Thank you, Don.
Thank you for joining us today. Dr. McNicholas's full paper is now available on the ERJ website, publications.ers.org.